I'm Dr. Cecchini, one of the medical oncologists at Yale and co-director of the colorectal cancer program here. I'm going to be talking about some of the medical oncology aspects of rectal cancer. This is a CME dedicated to colorectal cancer, but given our time that we've allotted for this session, we've decided to focus on rectal cancer so that we can be focused. So I'll be speaking. We have Dr. Kimberly Johung from Radiation Oncology and Dr. Vikram Reddy from colorectal surgery. And as we go through each presentation, they'll introduce themselves as well. So I'm going to start out again talking about the medical oncology aspects of rectal cancer. And we'll allot about 30 minutes per topic. Again, medical oncology, radiation oncology, and colorectal surgery. And there'll be time for questions that can either be entered into the chat or can certainly be addressed directly to us. So first, I'm going to talk about the role of total neoadjuvant therapy for rectal cancer. How does total neoadjuvant therapy, sometimes abbreviated as TNT, compare to standard preoperative chemoradiotherapy, which has been done since 2004, and which chemotherapy regimen to choose potentially if we're going to use a total neoadjuvant therapy approach. And also, we'll then spend a little bit of time talking about the role of immunotherapy for microsatellite instability, high rectal cancer, a small subset of patients, but this may have important implications for outcomes. So rectal cancer has been treated traditionally with chemoradiotherapy, followed by surgery, followed by adjuvant chemotherapy in the United States from the early 2000s. This is based on the SOUR trial, which firmly placed neoadjuvant chemoradiotherapy as a standard of care. And again, we typically used, in the United States at least, chemotherapy as an adjuvant in this setting. And in certain parts of Europe, of course, adjuvant therapy is more controversial, but in the United States, it's firmly considered standard of care for any clinical T3 or N1 rectal cancer. But over the last several years, for various reasons, which we'll cover, total neoadjuvant therapy has become a new approach, perhaps. And there's 4 contemporary studies, 5 perhaps before they've been published. Those 4 studies that I have in dark color here versus the Apr study, that is not yet published, but it has had some prelim data presented. I'm not going to focus on that study. That's a study focused on the potential analyzing organ preservation, so analyzing a watchful wait approach. But so we have the PRODIGE 23 study, the Rapido study, the STELLAR study, and the Polish 2 study. I'll focus on the first 3, and Dr. Johung will talk about some of the radiation aspects of these studies, and as well as the Polish 2 study. I don't have any slides about that. So the Rapido study made a splash at ASCO ASCO 2020, so a couple of years ago now. And this is a study that tried to look at the benefit of total neoadjuvant therapy, but it also tried to look at how short course radiotherapy might play a role in a total neoadjuvant approach. So it was a study that was sort of trying to answer 2 questions at the same time, which always makes it difficult to really interpret the results. So patients were randomized to either the standard of care approach, so this would be long course, close to 6 weeks of chemoradiotherapy, followed by a 2-month period of recovery and surgical planning, surgery, and then adjuvant chemotherapy. But important to note that the chemotherapy is optional. So this is a study, a Dutch study, and again, in Europe, chemotherapy is not always done in the adjuvant setting. So optional chemotherapy is adjuvant. So we can also see another departure there from what we would do in the United States for the systemic therapy. Experimental arm, short course radiotherapy. Dr. Johung will speak about the reasons for short course versus long course and how to think about that. But short course radiotherapy followed by neoadjuvant or total neoadjuvant KFOX here, or full FOX, so total neoadjuvant 5-FU platinum doublet followed by surgery. So we have several things that are going on different than maybe what we would do here under normal circumstances. We have short course radiotherapy, we have total neoadjuvant, and then we have patients in the control arm not necessarily getting what we would normally give because some of them are doing optional therapy. So it actually ended up being about 40% of patients in the control group that did not get adjuvant therapy. So, you know, some people would argue maybe this isn't really a fair comparison group as a standard of care group for our US patients. Maybe a more accurate control comparative group would be to restrict the comparison to patients that just received adjuvant chemotherapy, which perhaps will be done in the future. Future release of data for this study. But so the initial this has been presented and then now published in the Lancet. So what did we see from the outcomes for patients with total neoadjuvant therapy? So in the blue line here, we have the total neoadjuvant therapy group. In the red line, we have the standard of care group. And what did we see here? And we saw that disease-related treatment failure, so essentially an endpoint very similar to progression-free survival, is better, so less likely to relapse with total neoadjuvant therapy. Hazard ratio of about 0.75, that's significant. Also, distant metastases reduced with total neoadjuvant therapy. Again, a hazard ratio of 0.69, statistically significant. So we're seeing overall essentially PFS and distant metastases. But then when we look at local regional results, so regional failure, no real difference here with doing this total neoadjuvant approach. So that tells us that this PFS benefit, essentially a surrogate of PFS benefit, is primarily being driven by effective systemic therapy, doing what we say that it always does, eliminating micrometastatic disease. But to really become the standard of care, we need to see something like a survival benefit. So did we see anything like that? No, we absolutely did not in the study. So this is overall survival, and you can see these curves are very clearly negative. I think if there was maybe some more separation of these curves, one could argue with more follow-up from the study, we see a PFS benefit. This is a disease that can stay controlled for a long time when it's metastatic. Maybe with more follow-up, we see a survival benefit. But in this case, I think it's going to be pretty hard to show that given how overlapping these curves are. And you can see this is has a ratio of 0.92 with a P of 0.59. So no survival benefit. What about the pass CR rate? Now, this made a big splash as well. I think people get excited about the pass CR rate. And I don't think this is actually truly an appropriate endpoint to really be gauging too much of our decision-making on, for the majority of patients at least. You know, for example, if we were to delay treatment, surgical treatment even more after radiation, I'm sure we would see more pass CR rates. But if it's not improving overall survival and it's not changing the type of surgery we do in any statistically significant fashion, pass CR rates are not really super important at the end of the day, in my opinion. And we haven't seen that with most of the adjuvant studies. The different surgeries are the same for the most part. So that was the Rapido study. What about another short course study? So this was another study that is very similar. So in its design, so I think helps make the case for or against neoadjuvant therapy, having two studies that are very similar in their design. So this is the experimental design was against short course radiotherapy on the left here, neoadjuvant K-pox for 4 cycles, surgery, and then adjuvant K-pox for 2 cycles. So instead of total neoadjuvant, it's mostly neoadjuvant, mostly total neoadjuvant versus a standard of care, again, standard chemoradiotherapy, surgery, and then K-pox for 6 cycles. This was actually a non-inferiority study. Like the Rapido study that I just showed, not all patients got adjuvant chemotherapy. So actually 25% of both arms didn't get adjuvant chemotherapy in the study, but all the patients and then the experimental arm got the neoadjuvant chemotherapy. So that tells you already, as far as systemic therapy goes, the experimental group is receiving more of it because both groups are not all receiving adjuvant chemotherapy. This study was done in China, and it was not considered optional. We don't know all the reasons why patients in the control group, for example, didn't get adjuvant chemotherapy. So what are some of the survival outcomes we see? So disease-free survival, again, essentially a progression-free survival endpoint for patients that are non-metastatic. So we see a statistically significant technically hazard ratio, though only 0.88, favoring total neoadjuvant for this total neoadjuvant approach. So that's the same as the prior study, right? Essentially, we're seeing less relapse with total neoadjuvant. But in this, we are seeing, in contrast, we're seeing an overall survival benefit here. So we're seeing a hazard ratio of 0.67, p-value of 0.033. So unlike the Rapido study, we are seeing a survival benefit with total neoadjuvant or mostly neoadjuvant K-PLOX, short course radiotherapy compared to long course radiotherapy, surgery, and adjuvant K-PLOX. With that big caveat that we're comparing patients that essentially only 3/4 of the patients received effective systemic therapy in the control group, whereas the majority receive it in the experimental group. And you can argue, well, it doesn't matter. Patients are able to get it if you do the total neoadjuvant approach, and only a portion of them are able to do it if you do the standard of care approach. I think we need a little bit more information about who's not getting adjuvant therapy, though, because we don't find that 3 out of 4 kind of trial eligible kind of patients are not able to tolerate adjuvant therapy. So a little bit more information I'd like from the reasoning for lack of adjuvant therapy. So the other big study, and this also was presented initially the same ASCO as Rapido study, so the ASCO 2020. Yeah, so the other big study is PRODIGE 23, which was looking at intensifying the chemotherapy to FOLFOXIRI. And as a rule, a toxic or expensive or even inconvenient treatment might be justified if there's an improvement in overall survival or quality of life, but disease-free survival benefit alone is probably not considered sufficient if we're actually going to intensify therapy. So compared to the prior presentations, we're really kind of just talking about reordering the therapy. In this, we're talking about reordering and intensifying, right? So we better be able to show a survival benefit for us to comfortably say that FOLFOXIRI can become a standard of care. So what did they do in this study? They took patients that were randomized to the typical chemoradiotherapy, followed by surgery, followed by chemotherapy. Interestingly, 6 months of chemotherapy here, right? We would normally do 4 months in the United States. And then in the experimental arm, FOLFIRINOX for 3 months, chemoradiotherapy, long course this time and not short course, and then followed by adjuvant chemotherapy. So again, not truly total neoadjuvant, but mostly neoadjuvant or half neoadjuvant in this study. Again, how many questions is this study kind of trying to answer? It's trying to answer. It's not asking a question of different types of radiation, so that simplifies the design a little bit. But it is looking at slightly different chemotherapy schedule, even in the control group than we normally do, more systemic therapy. But I think that's okay. So what did we see in the PRODIGE 23 study? We saw a path CR rate. Just to, I think everybody focuses on the numbers, so I want to highlight them as well. Pathologic complete response rate, 28% with triplet chemotherapy, FOLFOXIRI. And I have FOLFOXIRI here. That's what we call it a lot in the United States. It's technically a different regimen. This was actually FOLFIRINOX, but very obviously the same drugs, just very similar, slightly modified dosing. So the pathologic complete response was 28% versus 12%. So FOLFOXIRI, short course, long course, it seems like with the total neoadjuvant approaches, our complete response, pathologic complete response rates are pretty consistent at the 20 to 25, maybe to 30% range. So what do we see in survival outcomes for these patients? So if we look at disease-free survival, we see a 3-year disease-free survival benefit that favors total neoadjuvant with FOLFOXIRI, 69%, 76 versus 69%. When we look at overall survival, this is not statistically significant, but you can see the curves separated there. That may change over time. We're seeing a disease-free survival benefit as more time elapses. We may see a survival benefit, but at this time, there's clearly not statistically significant survival benefit. But what about the metastasis-free survival? So again, 79% versus 72%. So we are doing a better job controlling systemic disease, just like we saw in the Rapido trial with this early use in increased intensity FOLFOXIRI. And I think that's where the hope of using a more intensive treatment like this is to hopefully increase control of micrometastatic disease and cure more of those patients. But we did not see that yet in this study. So when we talk about intensifying therapy, we want to be really sure that we are being safe about it, right? So how tolerable is FOLFOXIRI? So I think about this in kind of 4 periods of its use here: the neoadjuvant period, chemoradiotherapy period, the perioperative period, and the adjuvant chemotherapy period. So if we look at it in the neoadjuvant period, most people got through the 6 cycles of FOLFIRINOX without an issue, no new safety signals. Chemoradiotherapy period, 95% of patients with TNT made it through the chemoradiotherapy period versus 99% with the standard of care who went straight to it. AEs though through that period were similar in both groups, so I think it checks those boxes. In the perioperative period, so 92% of the patients that received FOLFOXIRI as induction underwent surgery versus 95% with standard of care, so very small difference. Postoperative morbidity was similar between the groups, so we're not seeing an increase in complications. We're also not seeing a difference, by the way, in the type of surgery people needed. So if we had hoped that this surgery was going to reduce the rates of APR, et cetera, we were a little bit let down. So I think that is important to note. Even that higher path CR rate didn't translate into necessary significant reductions in morbidity from surgery, at least in the entire study population. What about adjuvant chemotherapy? If you get total neoadjuvant, are you less likely to tolerate adjuvant chemotherapy? At least to start the adjuvant chemotherapy, the answer was no. 77 versus 79% of patients were able to start the adjuvant therapy, but TNT patients ended up receiving fewer adjuvant cycles. But overall, when you look at cumulative amounts of chemotherapy patients received, the total neoadjuvant arm still received more chemotherapy cumulatively. Again, about 21% here of patients in the standard of care group did not receive chemotherapy. So you are comparing a group, 100% of whom at least got some systemic therapy, and a control group, only 79% got any level of effective systemic therapy. So if we kind of summarize what the differences between these three or four trials. So they all had slightly different eligibility. The Rapido trial actually had the most advanced tumors, only allowing clinical T4 and 2 disease. But they all have very consistent results, or fairly consistent results. They used, in addition to having different stages essentially of eligibility, they all use different types of chemotherapy, different durations of chemotherapy in the neoadjuvant period, and therefore different postoperative regimens as well. But their 3-year overall survivals and disease-free survivals are all relatively similar in comparisons to their control arms, with the only overall survival benefit clearly demonstrated so far in the Stellar trial. So, is TNT a standard of care or the standard of care? And I want to say that it's really hard to compare these trials. How do you mix and match? Do you mix and match FOLFOX with long course, FOLFOXIRI with short course? It becomes a little bit dizzying to think about it. And so it's hard to say that ordering truly matters for survival benefits when the TNT groups are getting more effective systemic therapy in all the studies, because the rate of adjuvant therapy is underwhelming, at least for our US patients. One could argue, hey, that is real life, and people that get a surgery maybe aren't as likely to be able to tolerate effective post-treatment surgery. And so that it's easier to get in systemic therapy in the neoadjuvant period. I think that's one of the arguments in a more morbid surgical disease, pancreatic cancer, for example. But I think it's a little bit more complex here, because that's quite the case that we see in our patient populations here in the United States, that we aren't able to get in effective systemic therapy up to 30–40% of the time. It seems a bit extreme. So I think one of the confounders here is that these studies are all done outside the US, where less adjuvant therapy is used for rectal cancer. So we may be seeing mainly an effect that one group of patients is getting systemic therapy and one isn't, maybe 25% of the time. But in the end, for me, the positives outweigh the potential negatives here, and I'm using neoadjuvant therapy in the majority of patients. And certainly, I think this is a standard of care, and if an OS benefit is shown kind of across the board, it will become the standard of care. So I think some of my co-panelists will focus, especially Dr. Reddy, talking about the surgical benefits of this. We'll talk about the reduced time to ostomy reversal as a major advantage, the possibility of reduced surgical morbidity for low rectal cancer, certainly in selected patients, improved disease-free survival, possibility of OS benefit if there's longer follow-up, certainly in some of these studies like the British study. And we're not going to talk about, well, I'm not going to talk about watching weight much, but the possibility that's available for watching weight, of course, with TNT, that's not available without it. Disadvantages, I think there's a lower rate of therapy completion compared to CRT, that even though it is small. There's delay in time to definitive surgery, which can be important. And many patients cannot tolerate the long duration of systemic therapy, for example, studied in PRODIGE 23. So I think that brings me to my next point, that which chemotherapy regimen to use. I think FOLFOX, KFOX for at least 4 months in the majority of patients for the total neoadjuvant therapy is the approach most widely adopted, and I support that. FOLFIRINOX can be used for select patients that are younger fit, where local response is more meaningful for surgery, but I think there's insufficient evidence to recommend this over FOLFOX for patients, and shouldn't necessarily be broadly used yet. So we'll just spend a few minutes talking about the role of checkpoint inhibitors for MSI high rectal cancer that is non-metastatic. This was data presented at GI ASCO this year, which I do ultimately think will be practice changing, but small numbers because these are rare patients. So mismatch repair deficient colorectal cancer rectal cancer, is 5 to 10% of rectal cancer, mostly Lynch syndrome patients. Important to note though that these patients have chemo-resistant disease, and so the group at Memorial Sloan Kettering evaluated giving these patients a checkpoint inhibitor, so taking clinical stage 2 or 3 rectal cancer, giving an anti-PD-1 therapy, and then following them by endoscopy and an MRI to see if they responded and had responded or had residual disease, and then patients would go on to the standard chemoradiotherapy and surgery. And we know that the immune checkpoint inhibitors are very effective in systemic disease, and for various reasons that it's certainly been hypothesized for a while that it'd be even more effective in localized disease because there'd be less immune escape, and they'll go on. They certainly went on to show that. So that I just put this slide up to mention that they actually enrolled pretty advanced patients too, and they still showed great outcomes here. So almost all the patients were node positive, and certainly higher T stage tumors. What did they show when they did endoscopic follow-in? Essentially, all of these patients either got a near complete or a complete response within roughly 6 months of starting immune checkpoint inhibitors. What about looking at this radiographically by MRI? Again, almost all of these patients, and this patient was excluded from analysis because it wasn't on far enough, but all the patients analyzed actually got, again, a complete clinical response. So all 11 patients that have been followed for adequate duration to have their data analyzed had a complete clinical response. Again, this is an 11-patient study, but I think there will be perhaps more data looking at this patient population from other investigators and released from perhaps this team as well. It may ultimately result in this becoming practice changing in the future. So I think stay tuned. This is not approved yet for localized colorectal cancer. These patients need to watch very closely for progression because they're chemo resistant. I do think it'll probably be incorporated into guidelines in the future. So in summary, total neoadjuvant therapy can be considered standard for most patients where systemic therapy is planned, which is most clinical T3 and N1 disease in the United States. FOLFOX or KFOX can be used for most patients, and FOLFIRINOX for select patients. Immune checkpoint inhibitors will become a treatment option for localized disease in the future, but are not yet in the treatment guidelines. I think if anyone has any questions, we can take one question now. although I am not entirely sure, since I cannot see anybody but the panelists, whether a question can get to me.
I can't see anybody either.
Okay, they can go in the chat. So certainly, I'll answer this one question, and then I'll watch the chat a little bit closer after this. What is your current approach? My current approach is typically full FOX for 4 months, so 8 cycles, and long course radiotherapy for the most patients. But Dr. Johung will talk about the radiation selection and planning. But usually starting with systemic therapy for logistical purposes with full FOX for 8 cycles. Full FOX series certainly I've used in those select younger fit patients where I think they have more aggressive disease, but that is not my normal practice.
Right. I think our practice has been long course, and we'll talk about, I think, Mike, you talked a lot about TNT, so I'll probably skip over my stellar trial and Rapido that I have in my slide set so that we're not redundant. Try to focus more on short course versus long course. We probably could incorporate short course more into our practice, but I think everyone's just more comfortable with long course, and the patients do well. So I'm going to dig in a little into the nitty gritty of radiation so you guys have a sense of what we do for rectal cancer when we live down in the basement. So a little bit of the technique, and then we'll talk about short course versus long course. I'll touch on TNT, but I'm going to breeze over that fast because Dr. Cecchini covered it quite well. And then we'll leave watchful waiting to Dr. Reddy. So Kim Johung, I treat GI cancers here in New Haven. And I think one of the things we need to emphasize is that the treatment of rectal cancer is a team-based approach. So I'm lucky to work with these folks and a handful of others. And we really need to work together to get these patients treated. And it's a collaborative approach. And I think that's important to recognize. So with that, I'll get started. So plan for today is I was going to talk about what is the benefit of radiation therapy for rectal cancer? So local control benefit prior to surgery. That's quick. Dr. Cecchini already touched on the SOUR trial. We'll talk about different radiation techniques. So when you see in my note, should we do 3D conformal, should we do Imrt, what is SBRT, so that everyone has a sense of what those techniques are and how they're helpful for different scenarios. Then I'll touch on the standard long course chemo radiation versus short course radiation. And then do a quick review of TNT because I think we got a great review of that from Dr. Cecchini. So I'm just showing some rectal plans down here. This is a 3D conformal plan, and the one to the right is a Imrt plan, and we'll talk about the benefits of those two approaches. Okay, so why do we use pre-op chemo radiation prior to surgery for rectal cancer patients? Michael talked about this already a bit, but the benefit is local control. We don't see the overall survival benefit. So this is the classic German rectal trial, right? Which I think we all know about, that compares pre-op versus post-op radiation in patients with locally advanced rectal cancer. And what we see is that patients who have locally advanced disease, so T3, T4, or node positive, who had pre-op radiation, and this is long course with concurrent 5FU, now we more commonly use LOTA, compared to post-op radiation, the local control was improved in the pre-op setting. And really it's, if you contour these cases, is that I can see the tumor in the pre-op setting. In the post-op setting, I'm merging in the pre-op imaging and kind of treating where the tumor used to be. So I think that helps people understand why the local control benefit really exists in the pre-op setting. The other benefit of pre-op radiation is for those patients with distal tumors, right? We see an increased improvement in sphincter sparing surgery, so lack of need, sorry, my light is going off, for an Apr and permanent colostomy. So, there are some patients where the tumor is so distal and involving the sphincter that we know that it's not going to benefit them. But, for patients who kind of have that distal tumor where they're on the brink of needing an APR versus LAR, I think that is another benefit of pre-op therapy. Toxicities are less in the pre-op setting as well. But though, as I mentioned, no difference in overall survival. So that's why we employ radiation prior to surgery. So now I'm going to dig into a little bit of nitty gritty dorky radiation therapy techniques, but I think it hopefully is of interest. So what are these different things that we're talking about, and what are the techniques, and what are the benefits of using one versus another, right? In the setting of rectal cancer. So how we shape our radiation fields are with what we call these multi-leaf collimators. So these are tungsten leaves that are 2 millimeters or less, and they move in and out of the beam. So we can use them to shape the beam, but we also can use them to modulate the intensity of the beam. So if you turn the beam on and they come in and out during treatment, right, then at different times, each portion of the tumor target can be getting different intensity of radiation, which allows us to conform the radiation dose to our tumor target. And the goal here is dose the tumor, reduce side effects. So when we're talking about 3D conformal radiation, this is basically, in the old days, we would use an X-ray and use bony anatomy to set our fields. 3D conformal radiation just means that we're using a CAT scan, and I sit for a couple of hours and contour my tumor targets and contour the normal tissues around those tumor targets every 2 millimeters through the slice of the scan, so that we can use those contours to shape the beams to fit the tumor target and avoid the normal structures as much as possible. But you can see that when we do that for a rectal plan, right, we're shaped around the mesorectum, but we're still treating quite a bit of normal tissue around the rectal tumor. So that would be the downside of a 3D conformal plan. Intensity modulated radiation, or IMRT, that you'll hear us throwing around in the charts, is something that's a little harder to get approved by the insurance companies for rectal cancer, but I'm seeing it approved more commonly nowadays. So this I would think about as your radiation beam is divided into like these tiny little beamlets. So if you're thinking about a flashlight, each portion of the flashlight has different intensity. And then basically we're using a computer to optimize these intensities and the shape of the beam so that we can create concave dose distributions that really conform to the shape of our tumor target and try to decrease toxicity. I have more luck getting this approved for post-operative cases because there's more normal bowel that falls into the field after surgery. And I think it is more helpful for patients with T4 disease where we're treating external iliac nodes because the volume comes more anterior and there's more bowel that's in your field. But for a T3 case, probably a 3D conformal plan is adequate. So I think this is just a good pictorial of what an intensity modulated plan looks like. This is a head and neck case, but it can give you the sense that you have multiple beams targeted at your tumor with intensity of the beam, different across the entire area. And the other thing that IMRT allows us to do is differentially dose different areas of the tumor target. So for example, you can give gross disease a high dose and simultaneously elective nodes can get a lower dose, which is it's a convenient way to plan. So this is an example of an IMRT plan for a post-op rectal case, and you can see, right, compared to that 3D conformal plan that I showed you that was like a box coming across this whole area, right, we're really able to carve the dose out of this anterior small bowel and try to spare toxicity. So I think this is where we're moving if we can get insurance to play along with us. So then last radiation technique that I wanted to mention was SBRT. So this is stereotactic radiation therapy, which is really delivery of ablative doses of radiation in 5 or fewer fractions. So we use this in the brain or outside of the brain in the body. And where are we using this in the context of rectal cancer, right? Because that's what we're talking about tonight. So as I said, multiple conformal beams or arcs to deliver high doses of radiation with rapid fall off beyond the target volume. So if we use technology to be very tight with our dose distribution, then we can get away with giving high doses of radiation and protect the normal tissues. So, the technology outside of the brain really started in early stage lung cancers. We're using it in liver cancers, pancreas cancers, prostate cancers. But where we use it for rectal cancer is really in the setting of oligometastatic disease. So I wanted to touch on that briefly. So in order to deliver these high doses of radiation, we're quite precise with our patient setup. So this is what your patient is going to look like if you send them to me for SBRT. So we build something called a vac lock, which is a mold underneath them that holds them in position. I often put abdominal compression so that they're breathing more shallow. So it really looks like a blood pressure cuff shown here, but it's placed over their belly. And if they're breathing more shallow, then there's less respiratory motion of my tumor target, so my tumor volume is smaller. We then obtain usually an IV contrast CT scan from planning, and then what we call a 4-dimensional scan, which is really a video, and it shows me how the tumor moves. Right, if we have an oligometastasis in the liver, it would show me how that moves as the patient breathes so that I can focus my radiation on that path and tighten up the dose distribution. We always use image guidance, and I have a slide on that in, I think, the next slide, to help us align the patient appropriately for treatment. We often put markers in the tumor so that we can use those as surrogates to align the patient to be precise with treatment. And some places are using what we call respiratory gating, where you can treat the patient only in certain phases of the respiratory cycle, so only in deep inspiration or exhalation, in order to also reduce treatment volume. So basically the shape of the beam changes and the intensity across the beam changes as the beam arcs around the patient, and that allows us to deliver this tight dose distribution. So this is just an example of our image guidance. So we usually obtain what we call a cone beam CT on the machine. And that is something that we fuse in with the planning CT so that we can scoot the patient around on the machine and make sure they're in the exact same position as they were for planning, to be precise. So the purple, for example, is planning CT, and the green is what they look like on the day of treatment. And with that fusion, we get them into the perfect position. So how do we use stereotactic radiation in the context of rectal cancer? So I wanted to bring up the SABRE COMET trial. I'll touch on it briefly because I think we're focusing more on locally advanced rectal cancer. But since I mentioned SBRT, I thought this was important to talk about. So the question is here, in patients who have a controlled primary and only 1 to 5 sites of metastatic disease is what they looked at, with all metastases amenable to stereotactic radiation. Patients were randomized to just continuing on standard of care palliative chemotherapy versus that followed by ablating all sites of metastases with SBRT. Most patients had breast, lung, colorectal, or prostate cancers, so that's why I thought it was pertinent to our discussion tonight. And overall survival was actually increased when you, I'm distracted by Vic's screenshot there. So overall survival was increased if you use SBRT to ablate all lesions after standard of care chemotherapy. So increasingly, we're seeing referrals for patients who finish chemotherapy and may have 1 to 5 liver metastases or 1 lung metastasis and 1 liver metastasis. And actually, I'll mention that we are getting a new LINAC called the Reflexion, probably installed within the next year. We're going to be one of the first in the nation to get this installed. So Stanford has one now, and I think we'll probably be third. But the benefit of this is you can treat multiple oligomets at the same time. So now if I put a patient on the machine, I have to allot 30 minutes for each oligometastatic site. On the Reflexion, I can treat 5 at the same time. So it really increases output and also decreases patient burden. The other thing that the Reflexion does is tracks based on PET. So we'll be infusing PET tracer in our department, and then the machine communicates with the PET tracer and will track the tumor based on PET and move with the tumor during treatment. again, to tighten radiation dose. And the other exciting thing is, right, we can create a lot of advances in new biotracers for patients who have molecular targets. Sorry, my light keeps turning off. Okay. So those are me going into the nitty gritty of radiation techniques, and I hope I have not bored you to tears. I'm going to touch a little bit on short course versus long course, and then we'll talk a little bit about TNT. So the data for short course versus long course, I think, is really mixed and challenging to interpret. And I think the problem is as Dr. Cecchini touched on, a lot of the studies are comparing short course TNT versus standard long course. So you don't know if it's the TNT or if it's the short course that's causing the benefit, right? So I always start back at this old Polish study, which is a classic study looking at advanced tumors randomized to short course, followed by surgery, followed by chemo, versus standard long course, followed by surgery, followed by chemo. No difference in outcomes, but in terms of local control or overall survival. But I will point out that if you look at patients who have, so in this TROG study, which asked a similar question for advanced patients, again, no difference in local control or overall survival. But I think the important thing to note is that for our patients with distal tumors, there was not a statistically significant, but in absolute numbers, a hard to ignore difference in terms of local control. So I think for all of us, we're still a little bit wary about using short course for distal patients because of this data. And I can let Vic touch on that in his opinion when he gets a chance to speak. I think this is interesting because, so traditionally for short course radiation, we were following by immediate surgery. And so the question asked in the Stockholm 3 trial, right, was short course followed by immediate surgery versus short course followed by delayed surgery versus long course, where strangely they did not use chemotherapy. So I think that's a hard comparison. So in my mind, I look at this trial and interpret it as, should we be doing short course followed by immediate surgery, or should we be doing short course followed by delayed surgery? Everyone had a TME. There was no difference in the outcomes in terms of local control, METs, or overall survival. And so the final outcome was that short course with delay was non-inferior to short course with immediate surgery. I think the important thing to note is that the path CR for patients who had immediate surgery, right, was a lot lower than the path CR rate for patients who had delayed surgery. So I think, right, when Vic and I share patients and we do give them short course therapy, we're increasingly doing that with delay to surgery. I guess the question, Mike, would be, do we give chemotherapy in that interim, or do we just delay them to surgery? The concern was that there would be more complications if you don't take the rectum out right away after high dose short course radiation. But in fact, post-op complications were lower in the patients who had short course followed by delay. So finally, TNT, and I'll make this short because I think Mike really covered this well. So I think this is an interesting study that sort of sets the groundwork for the TNT approach, right? It's only a phase 2 trial. It's a small trial, well, 250 patients, not so small, but non-randomized. And we're really looking at long course followed by surgery or increasing cycles of FOLFOX prior to surgery. And you see that within each cycle of FOLFOX prior to surgery, the path CR rate is increasing. So in my mind, this is sort of like the setup for thinking about the TNT approach. And then Polish 2, Mike, I think you touched on this, so I'll also be quick. But really, we're looking at patients who have, again, locally advanced disease, randomized to long course followed by surgery versus short course chemo and TME. So now the problem is, right, we're looking at two different questions. We're looking at short course and neoadjuvant chemo at the same time as we're looking at long course versus short course. But no difference in outcomes in terms of local control, distant METs, R0 resections, path CR. And though 3-year overall survival was higher with short course, but the question is it higher because of the short course, or it's probably higher, I would say, because of the FOLFOX prior to surgery. And then if we look at long-term follow-up, the overall survival difference was lost for Polish 2. And then Stellar, I think we did discuss quite well, so I'll briefly talk about this. But again, this was looking at pre-op short course radiation followed by chemo, and whether it was not inferior to long course chemo radiation in patients with locally advanced disease. So patients are getting short course followed by 4 cycles of chemo, followed by surgery, and randomized to either TNT or long course chemo radiation. And there was no difference in survival or local regional recurrence. The TNT group actually had better 3-year overall survival, and acute grade 3 toxicities during pre-op treatment were slightly higher in the TNT group versus in the chemo radiation group, but I think we found this is tolerable for our patients. So as Michael said, I think we're moving more and more towards TNT for most of our patients based on these studies. Rapido, I think Dr. Cecchini also for and 2, looking at standard long course treatment versus short course chemo TME, with PASCR higher with TNT and distant meds lower with TNT. So again, I think supporting our practice change more towards TNT. I have NCCN guidelines in here. I don't think we need to review them because we can all look at them, but basically supporting more the use of TNT. So that's what I had. I'm happy to take questions. I went fast, but it's getting late, so I don't want to keep everyone on the line too long. Shall we hand it over to you, Vic? Oh, I need to stop my screen share, right?
Can you see my screen?
Yes, looks perfect.
So I'm Reddy. I'm one of the colorectal surgeons here. I'm going to talk about the surgical management of rectal cancer. I want to echo what Kim said. This is truly a multidisciplinary approach. And if anything, I actually use more services than I think Mike and Kim. We use the intrastromal therapy nurses. We use our anesthesiologist. And without all of these people, surgical management of rectal cancer will be impossible. Now, before we talk about the surgical management of surgery, I think it's important to look at the origins of surgery for rectal cancer. Surgery was usually very limited, mainly because of the high morbidity and mortality. This is like in the pre-1900s. Most of the rectal cancers were treated by transient excision. It was described by Liz Frank initially. It wasn't until 1907 that the traditional proctectomy that we see nowadays was described. This involved both an abdominal and perineal approach, and it was the abdominal perineal resection. And it wasn't until 75 years later that the holy plane of surgery that we currently use was described by Bill Heald in 1982. Now, in between 1907 and 1982, some surgeons were still doing TME, even though they didn't call it TME. But because they weren't doing TME, there were persistent high local recurrence rates. And because of this, there was a lot of interest in both chemotherapy and radiation, in addition to surgery for the management of rectal cancer. So the role of chemotherapy and radiation was mainly to decrease local recurrence, improve surgical resection of non-resectable lesions, and sphincter preservation in low-lying rectal tumors. We went through a phase of several trials. I'm not going to go through all the trials. Pretty much they all showed that multimodality treatment decreased local recurrence. So one of the important trials that I'm going to mention is this Dutch TME trial. Now, if you look at all the studies where they did surgery alone, local recurrence was about 28, 25%. When they added radiation, it dropped it down to about 12 to 14%. But if you look at the Dutch TME trial, surgery alone, by just following good surgical principles, had a local recurrence rate of about 10%. You throw in radiation after that, we dropped it down to 5%. So TME becomes the standard now. You know, we debated between short and long course, chemo radiation versus radiation. And then we finally come to this study, which kind of established what we do right now, or what we used to do about 10 years ago. And that was preoperative chemotherapy and radiation, followed by surgery, followed by chemotherapy. Local recurrence was about 6%. So the summary of the trials basically showed that TME surgery was important for all patients. It really dropped the local recurrence rates. And then pre-op chemo radiation with surgery and chemotherapy was the way to go. So now in recent times, I'm talking about 5+ years ago, patients got endoscopy, they got transrectal ultrasound, and they had two options. One, if it was an early stage cancer, either T1 or T2 lesion, they went for upfront surgery. If on the other hand, if they had locally advanced cancers, which was any cancer, T3 and higher or node-positive disease, they got chemo radiation followed by surgery, followed by chemotherapy. Now, we went from local pelvic failure of more than 25% by changing the surgical technique, and by adding chemo radiation, we changed our local recurrence from 25% to about 5 to 10%. However, about 30 to 40% still went on to develop distant disease. Now, none of the trials we looked at improved overall survival. They established roles for good surgery, radiation, and chemotherapy, but they didn't address any micrometastatic disease with upfront chemotherapy. Oops. They did not increase patient compliance, and they did not increase downstaging. Now, with chemo radiation, what we saw was that pathologic complete response was noted in anywhere from 10 to 15%. But the question was, can we do more? And this is where TNT comes in. There were a bunch of trials. I'm not going to go through all the trials because Mike and Kim did a good job. And pretty much every trial talks about increase in pathologic complete response. Now, the reason I focus only on this and not the other stuff is this plays a role in should we do surgery for rectal cancer if patients underwent total neoadjuvant therapy. So what are the surgical options? One, TNT changed this, so should none be an option. Then we talk about local excision and more radical surgery like LAR and APR, or even exempt for that matter. So let's talk about watch and wait. Now, when we talk about watch and wait, some of the terminology is important. You know, there's differences between induction chemotherapy, consolidation chemotherapy, and TNT is basically induction or consolidation chemotherapy. Now, pathologic complete response, you know, the definition of that is important because it's no evidence on pathology after proctectomy or full thickness excision. Now, some of these cancers, if you do a full thickness excision, you could still have tumor behind the rectal wall, which can't be excised with the transanal excision. So sometimes, even though we may say on a transanal excision specimen that there's pathologic complete response, it may not really be pathologic complete response. A few other things. What is a complete clinical response? This basically includes three things. One, there's no evidence of tumor on clinical, endoscopic, and radiologic studies. Clinical is digital rectal exam, endoscopic, you know, with the camera. Radiologic is with an MRI. And usually the lesion on endoscopy looks like this. Here was the rectal cancer, it's gone now. You have this whitish scar with some telangiectation. Then there's near complete pathologic response. So some tumor is present, but if you give it a little bit more time from radiation, potentially this area can disappear. Then there's incomplete pathologic response. And here you see the ulcer, you know, there's like a bed, there's some necrotic tissue. Likely this thing is not going to be a complete pathologic response. And these three things become important when we talk about watch and wait. Now, how did we come to watch and wait? A lot of this started looking at anal cancer treatment. So a long time ago for anal cancers, you had to have an APR. But then chemotherapy and radiation effectively melted away the cancer that now we do APRs for anal cancer just purely for salvage. And for rectal cancer also, we kind of saw it accidentally, like patients who had advanced age that no surgeon wanted to touch, or patients who had high comorbidities. When we gave them chemotherapy and radiation, we saw pathologic complete response. And as we waited, their tumors did not progress. And then we have a second group of patients where, they got chemotherapy and radiation, they didn't see anything inside, and they said, why am I doing surgery? So now we have tried to transition to more intentional watch and wait, where this is for less advanced disease. And if you get a complete or a clinical complete response, we follow them very closely and we see if you can get away without doing surgery. Now, the important thing for this is the selection. So the baseline stage is important. So when we stage them, if on MRI, the circumferential resection margin is less than 1 millimeter, likely this patient is not a good candidate for watch and wait. If they have extensive nodal disease, or if they have lateral pelvic nodal disease, they're not good candidates for watch and wait. The other important thing is that the tumor should be palpable on digital rectal exam. So if you can't palpate the tumor, they may not be a good candidate for watch and wait. Now, we also look at some endoscopic features to see if they're good candidates for this watch and wait approach. We got to make sure the tumors are small, they're non-circumferential. And if after you do the total neoadjuvant therapy, we got to make sure there are no strictures, because if there are strictures, it's kind of hard to assess that area. Now, once we have these selection criteria, if all 3 selection criteria are met, there's 98% accuracy in what we are doing with watch and wait. Now, digital rectal exam, again, is the most accurate. We need to get a baseline before treatment. Usually after treatment, if we see a smooth and regular mucosal surface on palpation, patients usually don't have, are good candidates for this watch and wait. On endoscopy, like I mentioned before, if there's whitening of the mucosa and you just see telangiectasias, they're also good. But if you see any ulceration, stenosis, or mass, they don't have a clinical complete response. Biopsies should not be done, because sometimes you only biopsy the superficial surface. Cancer may be found deeper inside, and sometimes this may yield false assurance to the patient. And if let's say the MRI shows a deeper lesion, they may not pursue surgery because they feel that, well, they found the cancer on colonoscopy. Now I see nothing. Why should I go for surgery? Lastly, MRI is important. This is where the radiologist comes in for us. On T2-weighted images and diffusion-weighted images, we can see if there's any residual tumor. Now, what kind of surveillance do we follow? After the patient gets done with Mike and Kim, they come to us, and about 6 to 8 weeks later, we start with digital rectal exam and endoscopy, and we get an MRI. If there's an incomplete response, meaning we see an ulcer, tumor, or anything like that, they go for a radical surgery. If, on the other hand, if there's a near complete response, it may be reasonable in some patients to wait another 6 to 8 weeks and repeat the digital rectal exam and endoscopy to see if they go from near complete response to a complete clinical response. Now, most of these patients, if you wait long enough, sometimes you have to wait 28 to 34 weeks, they do become complete clinical responders. Now, if on the other hand, there's no continued response or any growth, you got to look at proctectomy. Now, for clinical complete responders, what we do is we do a digital rectal exam, endoscopy, and MRI every 3 to 4 months. I usually tend to go every 3 months for at least 2 years. After 2 years, we decrease the frequency. We do it every 6 months for about 3 years. And then this is the key part, is that you got to go for this yearly, because we don't have long-term data. So if you're going to go with the watch and wait approach, we got to make sure our patient is committed to doing this every 3 months for 2 years, every 6 months after. Now, what is local regrowth? The risk of local regrowth is about 10% if you have, clinical complete response for 2 years. And the actual risk is only 25% at 2 years. And then most of these patients have aluminum components, so we can pick them up on endoscopy or digital rectal exam. Rarely do they have mesorectal or lateral pelvic sidewall disease. And the risk factors are basically increasing T stage. For every increase in T stage from T1 to T3, there's about a 10% increase in risk of local regrowth. After 2 years, if they're a complete clinical responder, there is no risk, and they're, just because they have a higher stage. Even if there's regrowth, 90% of these patients are amenable to R0 resections. I usually say if they're clinically T2N0, because they've had total neoadjuvant therapy, some patients may be candidate for transient excision. Some patients do go for proctectomy. Anything higher than that, they should go for a proctectomy. There is increased risk for metastatic disease. Unfortunately, if there's local regrowth, we don't know if it's because of tumor biology, but I think there's going to be more work on that. In terms of functional outcome, with watch and wait, all they're getting is chemo radiation. So their quality of life is so much better than with surgery. They have fewer defecation, urinary problems. They also have better sexual function. They have superior functional outcomes than even those patients who have had local excision. But about a third of the patients do have this LARS syndrome, which is low anterior resection syndrome, where they have frequency, urgency, clustering, occasional incontinence, but it is manageable and it does improve with time. Now, what about the future? Because now we don't know which patients respond well and become complete responders. So some people are working on actually cultures of the rectal cancer derived from the patients, and we treat them, and then we also treat the patient, and we see if these organoid cultures actually completely respond, and they may give us an indication on will the patient completely respond. Now let's talk about some of the surgical options. For surgery, it depends on where the tumor is. So the anatomy of the rectum is important. Any tumors lower down, chances of having an ostomy are much higher. So let's talk first about local excision. So local excision was described in the 1800s for benign tumors. It was kind of refined and perfected by Alan Park. He designed a lot of instruments. And the first real rectal cancer transient excision was done in 1977 at St. Mark's Hospital. In the 1980s, this guy was way ahead of his time, Gerhard Buse. He designed this setup, which is essentially a laparoscopic setup. It's transient endoscopic microsurgery, where you can go through the anus. It was the first natural orifice device where you can go through the anus and resect tumors even up to 20 centimeters higher. The problem with it is it's a very complex system and the training curve is very high. So it didn't get adopted. We do have it. We do these stem surgeries. Then they came up with a more easier platform, which is using the laparoscopic equipment in the 2010s. This is much cheaper, whereas the TEMS equipment is probably close to, I think, $250,000. So this one is much more accessible to all the institutions. Now, we do local excision for T1 lesions. They usually have to be histologically favorable. Usually we make sure they have no lymphovascular invasion, poor differentiation, or tumor budding. Unfortunately, we don't know a lot of this information until after we do the surgery. So if a patient undergoes transient excision for a T1 lesion, and if they have any of these bad features, lymphovascular invasion, poor differentiation, or tumor budding, they may have to consider radiation or proctectomy. Now, how about for T2 lesions? The problem with T2 lesions is that the local recurrence rate, if you do a local excision, is about 13 to 30%. Now, the main reason is because they have nodal involvement in 30 to 40% of the patients. Now, some patients are still candidates for local excision of T2 lesions. These are high-risk patients. And then there are some patients who absolutely refuse to have a colostomy. And sometimes you don't have a choice. You do something that's better than nothing. And there's data to show that chemo radiation may decrease local recurrence and also treat this occult nodal disease. And when we give chemo radiation, we see that the local recurrence is 15% as opposed to about 7% when we do a formal proctectomy. So it's lower than the 30%. Now, how about doing chemo radiation therapy first and then doing local excision? Now, there are several trials which looked at it, and they showed that it's got equivalent local recurrence and overall survival to proctectomy. So in select patients, it may be useful. The downside is that if you do chemoradiation or total neoadjuvant therapy up front, is there really a role, even for T2 lesions, is surgery even necessary, especially if there are complete clinical responders? Now, the problem with local excision after radiation is the post-op healing issues. Now let's talk about lymph node metastasis. Anytime we do a local excision, this is the biggest thing we worry about. It is directly correlated to the depth of invasion of the tumor. So for a tumor that's confined to the top 1/3 of the submucosa of the wall of the rectum, there's only 3% risk of nodal metastases. Now these are T1 lesions. Now the same T1 lesions, if they invade the lower third or the deeper third of the submucosa, there's a 23% risk of lymph node metastases. These numbers are almost close to the T2 lesions. Also, if they have lymphovascular invasion and poor differentiation, there's higher chance. There were some nice studies done which showed that lymphovascular invasion is associated with lymph node metastases and also with a 2.5x increase in systemic recurrence. This is a nice study done by Chang in 2012, where they looked at T1 lesions and T2 lesions, here's lymphovascular invasion and poor differentiation. And if you look at it, if they have both, it's almost 100% chance of lymph node metastases. Same for T1 and T2. Obviously, everything is worse for the T2 lesions. Also, poor differentiation, again, another study showed a 5x-fold increased chance of lymph node metastases. And that's why, if we have these risk factors, we try not to do a local excision. Tumor budding was initially described in 1993. The Japanese had a lot of literature on using it as a predictor and prognostic indicator of lymph node metastases. So we tried to do local excision for like the low risk patients. Now, how do we do it? Usually, we have these operating scopes, and we identify the lesion, get a 1 centimeter margin, excise the lesion down to the perirectal fat. Some people close it up and some don't. And here's how a TEMS approach with the transanal endoscopic microsurgery. Here you have the laparoscopic instruments. We actually use it, and we can actually go even up to the sigmoid, the pleurocecal lesions. This is how it looks for anyone who's in GI. It looks like an advanced ESD procedure. And there's a huge training curve associated with it. Now, even though it's the smallest surgery we do, there are complications associated with it. The biggest one is urinary retention. We also see bleeding. We see this in about 5% of the patients, or patients who are anticoagulated. And then the big thing is, you can see pelvic abscesses. These are a bigger issue for higher lesions where intraperitoneal entry is gained, but these can be managed quite easily. Now, what about the outcomes? One of the worst things about local excision is that we cannot harvest or stage the mesorectal lymph nodes. For T1 cancers, again, there's 6 to 10% risk of nodal metastases. And if you don't do a good surgery and there's positive margins, it increases the local recurrence and decreases the 5-year overall survival. For T2 lesions, again, local recurrence, it's not, the local recurrence is pretty bad, and the overall survival is slightly lower. But some patients are good candidates for this. Here's more outcomes. Risk of lymph nodes increase as the T staging increases. Also, local recurrence increases. There are several studies confirming these. So in summary, we do transanal excision for T1 lesions. If it's a high-risk T1, you can add in chemo radiation or do more radical surgery. For T2, we prefer radical surgery, but in some select patients, maybe transanal excision and chemo radiation. T3, no local excision, they go straight for main surgery, which we will talk about. So the radical surgery for rectal cancer is a proctectomy. It was initially described in 1907 by Miles. It was the abdominal perineal resection. We further defined what good surgery means in 1982 by Bill Hield. And why do we have to do TME? The reason is if you operate in the non-TME planes, local recurrence can be as high as 30%. And if you look at our circumferential resection margin, if you go right next to the tumor and get a margin of less than 1 millimeter, that's a 50% local recurrence rate. We don't have to do much better. If you just go 1 millimeter to the other side, local recurrence drops to 17%. By staying in TME, it drops to less than 10%. There's embryological origins for the TME plane. I will not go over this. There are different surgical approaches. We used to do a traditional open incision, and then we started going with the smaller laparoscopic or minimally invasive approaches. With laparoscopy, we insufflate the belly, use a camera, and use little instruments and do the surgery. Now we're using the robotic thing. It's ergonomically better. The surgeon sits here, and the robot sits next to the patient, and we control it to do the surgery. The visualization is phenomenal. This is how it looks. We identify the vessels. We can see, pretty much everything we need to see. And And still, again, for radical resection, PME is the standard. Local recurrence can grow up to less than 7%. The problem with rectal cancer is the lower the tumor is to the anus, the higher the chance of the leak. So the lower the tumor, the higher the chance of them having a temporary anastomy. And when we stay in these planes, there's nerves which wrap around this, which can cause erectile dysfunction in 10 to 30% of the patients. Some report even as high as 80%. And for the distal margin, we need about 2 centimeters. And if there's any question of it, we can even do a frozen section. Even 1 centimeter after chemo radiation can be acceptable in certain patients where the tumors are very low. Now, most patients want an LAR, which is a low anterior section syndrome. And this is a sphincter preserving surgery. There's different kinds. If it's a high tumor, you can do a standard LAR. For super low tumors, we do low, ultra low, or coloanal. Usually it's acceptable, even if the internal sphincter is involved. You've got to make sure that distal tumor margin is about 1 centimeter for us to be able to re-anastomose to the anus. Most of them do get some kind of an artificial rectum. Now, when we look at the anatomy, patients always ask us, well, why are you taking out my sigmoid also when the cancer is here? And the reason is it has to do with the blood supply. So we take out the sigmoid colon, the rectum, and this is an open surgery. Here we are dividing the sigmoid colon, descending colon junction, staying in the TME plane, identifying the nerves, dissecting out off the sacrum, taking it off the anterior, in this case it's the uterus, dividing it off the uterus. And then once we do this, we use retractors in open fashion, go all the way low, and then we try to transect it as low as possible, and then insert a stapler through the anus to perform an anastomosis. Laparoscopically, we use these little instruments. So here we're identifying the IMA that we need to divide. We isolate it and divide the IMV, and then free up the left colon. And then we take down all the attachments of the left colon, dissect the rectum off the presacral plane. Here's the hypogastric plexus that we identify and keep safe so that there's no sexual dysfunction. Here's a video of what this is doing the surgery robotically. So we're taking down the plane. In a quick second, you'll even see the ureter highlighting up here in green. We have a specialized dye that we use when we use when we use the robotic surgery. We're opening up the planes. This is the mesorectal plane, which is the loose areolar tissue. It's almost bloodless. If you look at it, we're just going through it quite fast. Here we are identifying the hypogastric nerves, preserving them so there's no sexual dysfunction. And we keep doing this. So I'll skip over this. Here we have isolated on both the right and the left side. Here's the rectum. The tumor is somewhere here. So now we're doing the distal mobilization. So, we're not coning down. We're taking the entire TME. We have identified the tumor here. So now we're marking it off. We're thinning it out. The margin needs to be about 2 centimeters. And once we do that, here we're dissecting it off the prostate and the seminal vesicles. And once we have done that, we use the stapler to divide it and extract the specimen. So in this case, the stapler really comes in, and we have cleaned out the rectal wall. You can see that all the muscles of the rectal wall, we're dividing it. And then once it's divided, the specimen is extracted, and then we do this anastomosis. And the fresh colon from higher up comes down and is hooked up. This is how it looks in real life. Here's a spike coming in from below with the stapler. The spike is going to get deployed on our staple line. Here's the proximal anvil that gets hooked onto it. And then anastomosis is fashioned in 2 layers with 2 rows of staples. And sometimes we actually oversew it. Here we're holding up the prostate and the bladder. This is us rearranging it, moving the fat out of the way so none of these get incorporated. So there's different colonic reservoirs we use. In this procedure, I showed you this one, which is called the Baker anastomosis. There's a J-patch or a coloplasty. I'll talk about why we use them. Most of the time, we do divert patients, especially after chemo radiation or if it's a low tumor. So this is a temporary diverting loop ileostomy. Now, the anastomosis can be done stapled or hand sewn. We prefer the stapled because it's easier and quicker and faster and safer for the patient. But in some situations, we have to do a hand sewn anastomosis because the stapler misfires. This is a stapled anastomosis that I showed you. The hand sewn is much more difficult. We get it. It's usually done open. It takes a longer time. So we usually staple misfires. Here's the tumor. It's being excised. We take off the cuff of rectal mucosa, pull the colon, and do a hands-on anastomosis through the anus. This adds about an hour to the case. Now, this is usually not done nowadays. Now, these are for tumors which involve the internal sphincter. What we do is we go all the way down below the tail line, right by the inner derm, divide it, pull the colon from above, and literally hook it up to the inner derm. The functional results from this are actually comparable to an APR, and patients have good functional outcome, meaning they don't have incontinence, even though they only have the external sphincter. This is more of historic interest, but we have about 2 or 3 patients where we've done this because they have a hostile abdomen. So we do a abdominal incision, and then we go through the back and we open up the coccyx, and actually under direct visualization do the anastomosis if they have a hostile anterior abdomen. This is recently of interest. This is called the Transient Pme, where the distal portion of the Pme is very difficult. So what they decided to do was, why not go through the anus, divide the rectum, go up a little higher, and then pull the colon down and do the anastomosis. It helps with the distal mobilization of the last 3 to 6 centimeters of the rectum, but there's some complications, is that because you're kind of doing it blindly, people have transected the urethra or caused rectal vaginal fistula, and these are bad problems. With good laparoscopic skills, you're able to do the distal 3 to 6 centimeters, so we are not huge advocates for the TAPME TRTL. In terms of functional outcome after anastomosis, it's conflicted. Because you're missing your rectum, some people do report good outcomes, but there's higher rates of incontinence and worse quality of life, especially in women. And patients experience this low anterior resection syndrome, where they have urgency, frequency, clustering, incontinence. Most of these symptoms do improve after a year, and colonic reservoirs, instead of just hooking up the colon straight into the anus, actually helps with this. These are the different options. The colonic J-pouch was described in 1986. Technically a little bit more difficult, very hard to do it in patients who are obese, patients who have diverticulosis, who have a bulky colon, have a shortened mesentery. This is how it kind of looks. It looks like there's capacity as opposed to a small colon. Coloplasty was defined as an easier approach, where you get this reservoir, but the problem is now you have an anastomosis here and another staple line which can potentially leak. So we try not to do this because there's a higher leak rate at the coloplasty side. Then there's a much easier technique where we do an end to side, leave about 3 centimeters of this and hook it up. And it has similar outcome to a colonic J-pouch, so we have now all transitioned to this. So in summary, you can do it stapled or hand sewn. We do use reservoirs. Patients do get a protective stoma. The one big downside is this low anterior resection syndrome. Now, this is the procedure described by Miles, which is the abdominal perineal resection. The absolute indication for it is if any external sphincter is involved, or if the patient is incontinent, even for the diagnosis of the rectal cancer. Some relative indications, if you're a tall, big guy, it's sometimes very hard to re-anastomose for low tumors. So sometimes APR is the only option. For APR, we do the same surgery, except they get an end colostomy. We do the same surgery as the low anterior section, but we also take out the anus. So here's an elliptical incision. We core down, divide the sphincters, and then reach from our dissection to the other side, and then we close up the anus. So it's used for patients where there's sphincter involvement. It's also used in patients who have incontinence, in obese or tall patients with mid-rectal tumors. We do an APR. There's very good long-term functional outcomes, but no one wants it because it's a permanent colostomy. Now, these are for locally advanced diseases. This is the pelvic examination. There's different forms of it. You have the posterior pelvic exam or a complete pelvic exam, where both bladder, uterus, and rectum are removed, or in men, bladder, prostate, and rectum are removed. Here's an example in men. We are mobilizing the bladder and identifying the dorsal venous plexus, ligating it. Then once we ligate, we divide the prostate and the urethra. Now it's fully unblocked, removed. So here's prostate, bladder, and rectum. And we take it out, and usually patients end up with two ostomies. One is a colostomy for stool, one is a urinary conduit because they don't have a bladder anymore for urine. The outcomes from these are great. 5-year overall survival is 53%. So doing a good operation upfront is better for locally advanced tumors, rather than doing the half-ass resection and then doing surgery for recurrent cancer. The survival drops to 20%. Now, recurrent cancer, because I mentioned it, it's beyond the scope of this lecture, but It's very difficult because you're in extra mesorectal planes, which means there's a lot of bleeding. It also goes into the lateral compartments. So you think about things like obturator. And it's very complicated because one, you have recurrence, you have had prior surgery, you have radiation, fibrosis. So these are usually miserable surgeries, but if done right, they can be life-saving for the patient. So in conclusion, rectal surgery is evolving, especially with total neoadjuvant therapy. Staplers have made our life easier. Functional outcomes are getting better. And the goals of treatment for us from a surgeon's perspective is local control, improve the survival, try to preserve the sphincter, bladder, and sexual function, and try to improve their quality of life. So if we start off with, there were no good surgeries and patients had bad outcomes. Then in the 1980s, we made a lot of improvement. We then did minimally invasive surgery. And now we're going back to no surgery, but we're getting better outcomes thanks to Mike and Kim and everyone else. So any questions?
Thanks, Vic. I'll pose one of the questions, or I'll leave one of the questions posed in the chat. So for clinically low distal rectal cancers that are clinically T2 versus instead of just taking these patients straight to TME and considering preoperative CRT followed by transient excision, what kind of sways you for referring those patients, I guess, over to us?
So for those, my personal preference, I like to do transient excision, see if they have any high-risk features, because once you do chemo radiation, you won't know if they have any of the high-risk features, like lymphovascular invasion, poor differentiation. So personally, I think it's much easier, and it's better to do transient excision followed by chemo radiation. But some patients do get chemo radiation and then come and see us, and we're never certain if they had any good features, because sometimes the tumor is gone. But in some patients, it is an option.
Great, thank you. I think all the questions have to go in the chat, so feel free to answer some of them by text, but feel free to put any questions in the chat. Otherwise, we'll just sit here quietly, since I don't think anybody can voice in that question.
Well, Dr. Reddy, I think one of the great points you brought up a few times during your talk is the question of survivorship, right? And I can be the first person to say I'm guilty of not doing the best job in that. And should we be looking into, building sort of more of a survivorship program for our rectal cancer patients in terms of sexual health, rectal symptoms, local symptoms, because they are struggling, and I don't know that we provide them the support that they need. And they come to me and I say, go see Dr. Reddy, but that's not helpful.
No, so we actually, believe it or not, after 5 years, we still follow the patients mainly for all their other side effects.
So do you feel like you're taking that on your plate, or can we do something more institutionally to sort of have a better colorectal survivorship, or even just GI in general, right, program? Should we enhance that? I think we do a great job with breast, but not such a good job with GI.
Yeah. So we've started, our APPs have started doing this more.
Okay.
Patients are happy about this. Before, we used to say 5 years, don't see us, and they had all kinds of symptoms. And they didn't know what was going on. They would reach out to everyone. We used to go on support groups, and they would just complain. But now we have made it a point that even after 5 years, we follow them. They come and see us once a year. If they see no improvement, then they kind of disappear on their own. But so they still reach out.
We should send them all to you, is what you're saying?
Yeah. Oh yeah. Even for the anal cancers, rectal cancers, anyone.
Right. I think they have chronic symptoms and incontinence for years.
Yeah.
Local symptoms, urinary symptoms, and I think they struggle on their own. So I think that's something we need to focus on more as a group.
The sad part is we even have patients with cervical cancer and prostate cancer after radiation that we're managing.
Right. Okay. Well, I'm glad for your collaboration on that.
Do you routinely therapy for like pelvic floor physical therapy, Dr. Reddy?
So that's a little bit more difficult because it has to be based on insurance companies. Pelvic floor therapy does help the patients. Sacral nerve modulation helps the patients with low anterior section syndrome. The problem with that is that you have to implant this device, and they can't get MRIs after. So a lot of patients don't want to go for that. At least for 5 years, we don't want to do it. A lot of times.
Trouble with who does pelvic floor therapy here?
we do.
Okay. I can't figure out how to put the referral in.
You,
So I
you
send
just,
them
you
out
just
into private world.
send them to us. So we get manometry and everything with GI, and then
So they can come to colorectal. Okay, so that's
Yeah.
great to know.
so one thing we're trying to do is actually, and mind you, is trying to advocate for a CPT or diagnosis code for LARS, so that there's no
Okay.
official code.
But I think that that's more directed pelvic floor therapy because there is someone like in YPB who does it. But
No,
I send the patients and they don't understand the issues, right? So
No.
patient comes back and they're like, what was that? It didn't help me at all.
and not only that, some of the probes that they use are very uncomfortable for patients, especially
Right,
after
right.
they've had radiation.
After treatment, that right. They don't understand the concepts. Okay, that's great to know.
And one of the questions in the chat, Dr. Reddy, is have you started adopting a wait and watch approach, watch and wait and approach in select patients who are surgical candidates?
It makes me very nervous, but we have. Sadly, I'm still, if someone who's 40 comes in, chances are we don't follow a wait and watch approach. We do advocate for them. Even a couple of times we have gotten burned for some patients who have had treatment somewhere else, and we have, they've seen local recurrences, and we have taken care of them. It's not that they did anything wrong. Sometimes patients, when they see a local recurrence, they kind of get upset with the people locally because they say, "Oh, endoscopy didn't show it, and you missed a cancer."
What's been your experience with salvage for those patients, Vic?
So if you get them in time, so it's interesting. Patients who have had endoscopy and the pathology has shown no tumor in the wall, those patients are more reticent to go for a radical surgery.
Mm-hmm.
So even if the MRI shows something, because the MRI will always say can't rule out tumor, or they're kind of nebulous, patients don't go for surgery,
Mm-hmm.
especially if it's an APR.
Mm-hmm.
So those patients, unfortunately, they come with locally advanced disease, like their circumferential resection margins. I mean, we had someone who had who done a memorial who almost had a near complete response. After about a year, started having symptoms. Endoscopy, biopsy didn't show anything. One of our endoscopists actually did a deeper biopsy because I couldn't convince the guy. Found cancer. He had a 10-centimeter lesion with all circumferential resection margins positive, and he did not want the pelvic examination. It was positive on the prostate, so his survival was going to be impacted. And
what I found too is I think promising a patient the option of watchful waiting up front is challenging.
It is.
Because they say this was proposed to me as an option, or I read about it, and I always tell them we need to wait to see what your response is to therapy. We cannot commit to this day one, right?
I agree.
So I think that needs to be made clear to patients.
And not only that, I mean, how many of we have patients who, this because they all complain to you, because I do a rectal exam after radiation and they're like, "Oh, I can't tolerate this." And if you can't do a rectal exam, I think watch and wait is it's not.
Right. It's clear that there's residual disease, right?
No, even if there's not residual disease, it's
that you're not able to surveil them is what you're saying.
Yeah.
Right. Yeah, I got that.
Yeah, I think my view is we'll see the final results from the Oprah trial or Opera trial. I get different pronunciation before I think this gets more mainstream.
Though I do think moving our program forward, right, we should probably start to consider this more for select patients.
Yeah. And not only that, we're seeing complete response rates of close to like 30%.
Right.
Compared to 10 to 15%. Back then I used to only feel bad 10 to 15% of the time that I did an APR and LAR and there's no cancer. Now I got to feel worse. 30% of the time I feel worse.
Right. Other questions from the group? Got 21. You're still holding on.
We did set this to go until 8:30, but I think the goal was about 30 minutes per presentation with questions. So we are at around 8 o'clock. If anyone has any burning questions, you can either put them in the chat before I finish talking or we finish talking, or you can email us directly, of course. Our emails are our first name, last name at yale.edu and on the website.
Happy to communicate.
Parting words.
Thank you for organizing this. I think it was great.
Thank you, Mike.
Thank you all. Have a great night.
All right, go Rectal team. See you soon. All right, take care. Bye-bye.